Olá, amigos. Hoje eu vou conversar com o Dr. John Marshall. Ele é diretor do Serviço de Oncologia do Hospital MedStar da Universidade de Georgetown, em Washington, nos Estados Unidos. Ele tem muita experiência com medicina de precisão, biologia molecular e uma grande autoridade internacional em tumores gastrointestinais. Ele também é consultor da AMO para assuntos relacionados à biologia molecular e novas tecnologias. Vale a pena ouvir e acompanhar essa conversa.
Thank you very much for participating. So, we know the importance of precision medicine, and we look forward to seeing it really in practice in oncology services. I'd like to ask you, how close do you think effective adoption of precision medicine is from being available for daily use?
We have to remember that all of us learned that cancer was sort of one thing, and we have quickly come to understand that cancer is many things, and it is being driven by the science of precision medicine. So how best to treat the patient in front of you depends upon increasingly every day the molecular characteristics of that cancer. We know it in breast cancer, ER, PR, HER2. We know it in GI cancers, colon cancer, RAS mutations, BRAF mutations, microsatellite instability, HER2. We know it in lung cancer. All of the different mutations that are present in lung cancer totally drive our therapies, totally drive our prognosis and prediction of appropriate therapies. And so it's not a question of when this is going to become the standard, but how quickly will we all adopt it across the board. So we know today that cancer is not all one thing. We know that we can't use a one-size-fits-all treatment approach for our cancers. We know that molecular characteristics of our cancers are defining new pathways, new structures, new therapies in order to treat most effectively our patients who are sitting in front of us. And you can't tell that simply from a CAT scan, simply from a typical pathology report. We are dependent upon precision medicine today. We know that almost every cancer has to have some molecular test being done. We know that in breast cancer, we know that in lung cancer, we know that in GI cancers, and so many others. The question really is how much can we learn from precision medicine? How deeply can we explore the molecular characteristics of our individual patients' tumors so that we can become the best clinicians with the best cure rates the most efficiently? And I believe precision medicine will be the answer to that.
Okay, we all know that cost is a very big issue in oncology. The increasing costs of oncology are very worrisome for the payers and also for the patients. Do you think that these new technologies will be cost saving as indications of treatments and exams get more precise and more cures are achieved, or it will be like other technologies that just have been adding more cost to the system?
We are so used to having new technologies just add cost to the system. But I actually think precision medicine is exactly the opposite. That this is relatively affordable technology compared to, say, a CAT scan, a PET scan. This is the same cost as that. And what we are going to learn from that is how to be more efficient. Yes, in some cases, it will identify new therapies that are today pretty expensive. But what it's going to also do is make us more efficient in not giving therapies that won't work for patients. So much of our world today is trial and error, And if you think about, if I can look at a patient and say, instead of giving you 8 weeks of something to find out that it doesn't work, that I know right now it's not going to work, you think about the cost savings of that on the patient, on the society, on the healthcare system. It's dramatic. when I think about the concept of circulating tumor DNA as a tool to define who should get adjuvant therapy, who should not get adjuvant therapy, this is going to transform our effectiveness, our cost savings in saving people from getting chemo that don't need it or who shouldn't be getting it. So counterintuitively, this is new technology that I believe strongly will lower the cost of cancer care.
Okay, let's change subject a little bit. And I'd like to know, in your personal opinion, how well are oncology services prepared to deliver humane and warm quality care for patients and their families? How can we improve on that?
So I think a lot about the care that we deliver. I run a big cancer center here in Washington, D.C. You guys run an incredibly productive and well-established cancer center in Bahia. And so we know the challenges that we're facing. On the one hand, we want to provide a level of care for our patients that we would want as our families receive, right? We would want to be that on top of things, that supportive. But if you do that across every patient that walks in the door, we recognize that it's very, very difficult to deliver care at that level for everybody who walks in the door. And so we're constantly having to make trade-offs between not trading off anything about quality of care and outcomes, but some of the personal touches that we all would like to be giving day in, day out, we know we fall short on. In fact, when my own wife experienced her breast cancer 15 years ago and was getting care, I then got to see the other side. I got to be the caregiver, the spouse, going through a system and understanding just how dependent our patients are on every word we say, on every visit, on every scan result. And we, of course, received incredibly great care because we were family. We were being treated by family. And so I think on some level, we should strive to deliver care at that level, as close as that level as we can come without breaking our own system and our own hearts.
So you had a chance, as you mentioned, to visit our practice here at Clínica AMO and see the work we do here in Salvador. Was this experience any different from what you predicted? What was your impression of what we do here, and compare it with the practices in the US you are used to seeing?
So I have been lucky to have visited cancer centers around the world and experienced different levels of cancer care, different processes of cancer care around the world. And I was incredibly impressed by what I saw at AMO. The quality of the facilities, remarkable. The quality of the people, of course, is the biggest part of what AMO is all about, and how they are driven, how you all are driven to deliver the highest quality care. Everyone is smart, and that's true on a global scale. People know the business. They're reading the same journals. They understand guidelines, and they understand what needs to be delivered. Where it differs is in access. And some here in the United States, and it's always something that we deserve being picked on for, we have unlimited access. But that doesn't necessarily mean that our outcomes are better. And when you look at a place like AMO, I'll bet you your outcomes are just as good as my outcomes, even though we might have different levels of access to proton beam machines and cyber knives and fancy scans here and there. Now, that being said, we are so much more alike than we are different. The ability to deliver multidisciplinary care, high-end tumor boards, high-end imaging, high-end therapeutics. I would feel very comfortable having me or my family cared for by your team at AMO.
Thank you so much. So just to finish, I'd like to know what opportunities oncology service like ours can gather from clinical research and genomics and precision medicine especially talking about this partnership with Indivimed, we are just about to launch.
We are so excited that you guys have joined in into this global collaboration of precision medicine in cancer. As we have dug deeper and deeper into the secrets of tumors using broad multi-omic molecular medicine, we're discovering, in fact, regional differences, global differences in what makes a cancer tick, what drives cancers, frequencies of molecular markers, for example. And I do think that what we are doing together will, in fact, help your patients locally, that we will be able to demonstrate particular needs. We will be able to bring to your team and your patients more research, more access, because they will be characterized. We will know what patients you are taking care of and treating. And this is a multi-year long-term project. So while we want early results, we know that really what we are looking for is 5 years, 10 years down the road of having the world's best cancer database. And your patients will be part of that. And so I think it brings global attention, global resources to your site. And as a result, I believe it will bring better outcomes for your patients.
Thank you so much, John. Have a nice day there.
Bye-bye, Alex. Take care.
You too.